translating the enormity of genomics into clinically useful and meaningful information is really daunting. So with that in mind, that's why we're here, and I am standing with Jill M. Johnsen, who is an MD at Bloodworks Northwest Research Institute and an assistant professor of medicine at the University of Washington, Seattle. We're talking about guiding hematologic care with genetic testing. You know, the whole promise of genetically informed, personalized clinical care has been tantalizingly out of reach now for some time. It just seems like it's tempting us, but it's not here. Where are we with this?
We are almost here. We are fundamentally here. So the advances in technology have really changed the scale at which we can do these molecular typing. We've known for decades that we would like this information, and hematologic diseases are at the forefront of genetic diseases because they fundamentally are very easy to phenotype, and they are, for the most part, genetic, either germline or somatic. So we have been doing fundamentally genetic testing for decades through our phenotypes and through some very low resolution typing, and now with the advent of scale sequencing and arrays, we can take this information and bring it to the clinic. As we have an advantage as a field because we know what to do with this genetic information as opposed to other fields where actionable variants are harder to identify.
So you're ahead of the curve.
I think as a whole, hematology leads in genetics.
Well, you say this session at ASH 2015 seeks to make the conversations occurring now at the forefront of genetics accessible to the hematologist.
Yes.
So what are the topics of this conversation?
So some of the topics are using language from the genetics field that a hematologist can understand and translate into action and also interpret for their patients. So we all need to have a common language for this. So we need to understand, as geneticists, we need to convey what is it we have found in the DNA and what does that mean, or what do we think it means, or we can even have uncertainty, and then the hematologist needs to be able to understand that language and translate it into the language they're used to, which is the hematologic disorder that they're trying to treat.
Now, one of the topics you're talking about, next generation sequencing.
Yes.
What's that?
So next generation sequencing is it's a group of techniques that can do DNA sequencing at scale. So now we can do whole genomes, and we can do whole genomes. The costs are coming down to within reach of using them for clinical purposes. We can do targeted sequencing, which makes things faster, or the read depths are greater, so we can do a lot of interesting things with structural variation that we hadn't been able to do before. With the cost and the scale and the throughput, that brings assaying many variants at the same time, many regions of the genome at the same time, more possible. Whereas before we had to say, we're going to go look for a single variant, the sickle cell disease mutation, what have you, and you know that's there, but you don't know what other modifying variants might be around. So fortunately, these assays, which the industry has developed and in partnership with academia, are already going through FDA, and there are CLIA-approved processes that make it so that the clinical lab people can implement them now, and we all need to have the conversation of, what are our priorities to understand what the results are.
Now, there's also a discussion on the promises and limitations of targeted disease gene sequencing and the role that of identifying or not identifying, as the case may be, genetic variants has in the diagnosis of hemophilia and von Willebrand disease.
Yeah.
That sounds exciting.
It's super exciting. We think of them as single gene disorders, but the genes are complicated, and they have a lot of different variants that we know have implications for the patients and their families, because we have both a patient who has a disease, and then we have people at risk to be carriers or to have incomplete penetrance, which is where you might have it and not be very sick, and then your offspring has it and they're very sick. Right. We need to understand how to counsel people on those things. By doing targeted sequencing, we can zoom in on the question we want to ask. In some ways, it liberates us of incidental findings where we don't want to ask those questions of the genome or have a lot of uncertainty.
Now, one topic that caught my attention was the detection of sickle cell trait and the downstream clinical and social implications of making this diagnosis in an at-risk population.
Yes.
Because once you have the information, what happens and what does that mean for the patient?
Right, and sickle cell trait is a great example of return of results and the challenges that you can have for a variant where this is a variant. A sickle cell trait is when you have one copy of sickle trait variant and one normal copy. And so they don't have sickle cell disease, but it doesn't mean that they aren't significant considerations in returning that result to a patient and their family. And so the conversation around genetic results, particularly in communities where genetic information is not commonly disseminated or there are other social issues, the delivery of sickle trait information to those patients and their families is a very important conversation to have as a community, and it also sets the template for how we would return other results with similar clinical implications.
And one of the points you made earlier in our conversation here is that the conversation is a little bit difficult because your field does have its own dictionary of terms, so trying to explain everything isn't easy.
It isn't easy, especially because even within hematology we have many subsets of disciplines.
Exactly.
And we may all talk about the same thing using different terminology. So a unifying language is one of the most important things to communicate and leverage the advances we have in technology to personalize and the care for the patients.
I mean, some of this I suppose is here now, but what's kind of the time frame in terms of moving some of these genetic issues into clinical practice?
So it's always an evolution. We have been using arrays in clinical practice for a long time. We are using targeted next-gen sequencing in the clinic now. At this point, it's the partnering different questions with the capabilities that are evolving very rapidly underneath us to make sure that we're asking questions thoughtfully of DNA, and also to take advantage of the discoveries that come from looking at whole genomes to adjust how we ask those questions going forward. So it's an iterative process, and we're in the middle of it now.
This has to be fun
It's
to
so
be where you are
fun.
right now.
It's very fun. It's an exciting time. It's a really exciting time. We've opened the lid, and it's shining inside. So we wanna take that information and make it not scary,
right,
because if it's unfamiliar, and take the language and share it, so that the patients and families and communities understand that we've always had this variation all along, and now we understand that it's there, and we need to understand what it means.
It's a daunting task, as I said at the open, but thank you for trying with us. And for ASH 2015, there's all kinds of clinical news for you on ASH Clinical News. I'm Rick McGuire.